Greetings, this is Adam again, and we're going to continue our talk on endocrinology. And so we were discussing insulin and its uses in both type 1, type 2 diabetes, but focusing again on type 1 and talking about their regimens. For the most part, they really need to be tailored to meet the patient's lifestyle. That's why we can try to be flexible with things like using subcutaneous insulin pumps. They give a kind of continuous use of insulin, so that way they're not injecting themselves multiple times a day. But a lot of it depends on how compliant they are with therapy, how good they are with their diet. And so the most common way that you're going to see insulin being used, especially in the initial stages, will be this basal bolus regimens. We've kind of mentioned these already, but essentially you're going to have long-acting forms given either once or twice a day, depending on the form being given as kind of a basal insulin to try to provide kind of baseline levels throughout the day. And then you have bolus doses of the short-acting insulins around meal times to deal with that kind of acute increase in blood glucose. So it usually requires multiple daily injections. For the most part, usually anywhere between 3 to it can go up from there for sure. So sometimes 4 is probably the most common. I would think sometimes 5 or 6. So it just depends, right? The more frequent that you're giving insulin, the more often you give it, you're going to see better glycemic control. They usually talk about tight glycemic control, meaning you're keeping them right within the range that you've kind of set for them. And then that also means increased complexity. It also means probably more injections, which may be not so preferable for your patients. Less often, if you're given fewer injections, you typically see lower chances for hypoglycemia, just because anytime you give more insulin, you're going to potentially see anytime you give more insulin, you're going to see hypoglycemia, but that also means you have looser glycemic control. So you might have a tougher time keeping them in the range you're looking at. You can have kind of wider variations in their blood glucose in both peaks and troughs. So one of the other things you have to consider is you have to match the carbohydrate intake of their diets with their insulin and also physical activity, because physical activity will also use up glucose. And so in those cases, you may need to use less insulin around that time, right? We should always be encouraging good physical activity for most of your patients. But the goal here is to make sure that our patients can live as normal a life as possible and try to make sure their diabetes regimen and therapy does not really interfere with their lifestyle. And so ideally, if you were to give insulin, and you kind of see this with the subcutaneous continuous insulin pumps, it should mimic the pancreas as much as possible. So in the ideal world, we would have some sort of probe or something in the body that could continually monitor blood glucose, and then you'd have a pump giving subcutaneous insulin that could respond immediately to peaks and troughs in the blood glucose. We're not quite there yet. Certainly, we're getting better ways to have more consistent measurements of blood glucose, but nowadays we still have to use the finger sticks for the most part, and which can be problematic for some patients as well. But essentially, looking at the timing of the insulin, you have to consider the different dosage forms and whether they're fast-acting or long-acting, because they're going to have different onsets, different peak duration, peak times of activity, and the duration is going to be much different. And so really you have to end up matching what their meal patterns are and their exercise schedules. This is why you don't see patients usually getting, at least with type 1 diabetes, getting away with once or twice daily dosing regimens. It just isn't really sufficient to really mimic what that patient would be experiencing had they had a pancreas producing its own insulin. There would just be too many kind of inconsistencies and getting really hyperglycemic, so you can't really do that. So again, I bring this picture back up just so you can kind of see kind of what we're referencing here. Again, you're always going to have some basal amount of glucose in your body, because if you had no glucose, you probably wouldn't be alive. And so to deal with that, you're always going to have some basal amount of insulin as well that's being released throughout the body. So that's why we use our long-acting forms to kind of provide that nice kind of low-level basal insulin. And then around the meal times, when you have big spikes in your blood glucose due to carbohydrate intake, you're giving insulin as well in order to deal with that. So this is why we normally use, say, 4, maybe 5 daily injections in order to try to mimic this process as much as possible. And so generally the insulin doses can change depending on the carbohydrate intake and also their exercise. We mentioned that the long-acting insulin doses are taken usually either in the morning or in the evening. And then the regular, the ultra rapid insulin doses are usually taken around meal times, right? So there's kind of two main ways that you can see insulin doses being given. Sliding scales are probably very commonly seen, especially when you're dealing with like patients on the in the hospital on the inpatient side. Oftentimes, this is more of a kind of reactionary way of dosing insulin, where you are changing your insulin dose based on what their glucose readings are. So in this case, when you're doing it around meal times, you would do a preprandial glucose or before they ate, and then you would correct the amount of insulin that you did, because again, it slides, to lower their glucose. And so typically, based on your patient's insulin sensitivity, they'll have a correction factor associated with that, so that you'll have a good rough idea of how much 1 unit of insulin will change your blood glucose, how many ever milligrams per deciliter it might be. Every patient will be a little different. If they are more insulin resistant, meaning that they have a tougher time, their tissues have a tougher time dealing with insulin. That means that you'll have a smaller change in blood glucose, whereas if they're more sensitive to insulin, 1 unit can have very wide changes in glucose. So that'll change based on your patient and kind of what their previous history is. Okay. The other way to dose that rapid or ultra rapid acting insulin is to do carbohydrate counting, where based on how many carbohydrates the patient is going to be ingesting, they can adjust their dose based on that. And again, they will find that based on their insulin sensitivity and some other factors, that the patients will have a good idea of how 1 unit of insulin will kind of affect them. And so they kind of know okay, this many grams of carbohydrates, I'm going to do this many units of insulin. And so this is obviously more difficult because it requires a pretty good insight into just how many carbohydrates you're ingesting. So, for instance, if you imagine the next meal you go eat, try to estimate how many carbohydrates you actually are eating, right, for that meal, and then see if you can actually measure it to determine how close you really were. This gets easier with a lot of like aids, especially like on your smartphones. If you have stuff like MyFitnessPal or other kind of food libraries, it's a little bit easier to try to determine just how many carbohydrates the patient's actually ingesting. And after a while, they get it becomes second nature to a lot of them. So I see, especially with our pediatric endocrinologists, they're really shooting more for the carbohydrate counting method because this can be a lot more kind of proactive instead of dealing with the sliding scale method, which is more reactionary based on what their blood glucose readings are. The carb counting is much more kind of proactive, and you're dealing with the carbohydrates even before they enter the body. So just a couple of different regimens you might see out there in the real world. So here's a picture looking at the different forms of insulin to see how they kind of differ in their release characteristics and their activities and things like that. So here on this first graph here, we have our glucose concentrations. And notice here you have your kind of basal glucose levels in your kind of light gray area here. And then when you have mealtime stimulated glucose, you have these big kind of spikes, right? So breakfast, lunchtime, and then dinner time, right? So that's where you normally would see your jumps in glucose at. If you're looking at normal plasma insulin concentrations, you would see that, again, this would have kind of a basal insulin level, which you can see that light gray area. And then you'd have kind of a commensurate increase in insulin levels along with glucose intake. Okay, notice how it kind of has this kind of bimodal peak that you can see with this. Unfortunately, we don't really capture that super well with the insulin that we're using nowadays. That could be something that things like artificial pancreases would be able to kind of mimic in the down the road. So how can we dose our insulin in order to help deal with these spikes in glucose and trying to simulate what the pancreas would normally doing with insulin? Well, here you can look at this first regimen where you would use, this would end up being a 4-time, actually it looks like a 3-time daily injection of regular insulin, which we mentioned is kind of short acting, along with NPH insulin. That's that protamine containing insulin that is more intermediate acting, right? Usually get around 12 hours-ish of coverage with an intermediate acting insulin like NPH. So notice here that the dark solid black line is going to be for regular insulin, and then the kind of the dashed line is for the NPH insulin. You can see here that it takes a little bit of time for the peak to occur with the regular insulin. You'll notice when we look at the short-acting, really ultra-short-acting ones, that the peak happens even more quickly. And then here you would have both injections of your NPH and your regular insulin. The NPH, notice how it peaks much later, even around lunchtime. So that kind of covers your lunchtime dose of insulin to deal with your blood glucose there, even though it was taken in the morning. And then around dinner time, I take another injection of regular insulin and pH. This is actually be a twice daily regimen here now that I'm looking at it. Again, you notice that it doesn't really mimic quite as well what the actual insulin release is in the body. Really, you kind of get all-day coverage, but it's not super tight. You may not be able to get really good tight control of the glucose with a regimen like this. The preferable part, though, is that the patient's only having 2 injections a day, right? Patients typically like not having to inject themselves with sharp needles, so the fewer injections, usually the better it is for your patients. Okay. The next one here, you would have a regular insulin mixed with an ultra lente. Clinically, I don't see ultra lente being used really ever, so you can probably kind of change this out for something like an insulin Detamir or Glargine or that Degludec, one of those really kind of long-acting insulins. But essentially, this would be a 3-time daily regimen of injections where you do regular and ultra lente at the same time. And then you see that the regular insulin, would end up having coverage for the breakfast time. You would end up doing another dose of regular insulin around mealtime, lunchtime, and then around dinner time, right? So you have those 3 injections, and then the ultra lente kind of provides a good all-day kind of coverage to try to simulate that basal insulin release, okay? Again, the long-acting ones will do the same thing here, usually providing around 24-hour coverage, okay? If you have a patient with a insulin pump, you can see that this most closely mimics what the pancreas would normally be doing. You can see that it gives a continuous infusion, so you always have some baseline level of insulin being released by the pump, and then the patient will have boluses that they'll actually program in based on what the carbohydrates that they're intaking are usually. That if they're doing a sliding scale based on preprandial glucose readings, they can do that as well. But for the most part, I see them do a lot of carb counting. And again, these kids, especially the young kids you see, they're very good at knowing their carb counting ratios, and they can do this math in their head a lot of times, and they get very, very savvy at managing their own diabetes. Okay, so again, this would be the most similar to what the actual body is. But with all these injections of insulin, if a patient was not complying with their diet, they weren't really good about checking their glucose appropriately, you can see how this could be running the risk of having hypoglycemia and some other problems. So really, this is really meant for patients who are very well controlled on subcutaneous injections already. They're very compliant with their with their therapy. This is a good regimen for them since they don't have to have continuous injections throughout the day. So I'm not going to ask you to memorize the dosing for insulin for these type of patients. I just kind of want to use this for a frame of reference. Again, we mentioned with type 2 diabetes, the problem is that those patients, typically due to lifestyle issues with diet and things like that, they're constantly assaulting the body with too many carbohydrates. And that kind of wears out the pancreas, right? So the beta cells start to deteriorate, not really releasing as much insulin as they used to. And then the skeletal muscle tissue and the liver end up getting resistant to that insulin as well. So you can kind of compare someone like a type 1 diabetic who may be newly diagnosed and who has no insulin resistance to speak of. Their dose for insulin in units per kilogram per day would be anywhere between 0.5 and 0.6, right? So not a ton of insulin being given there, at least early on. With type 2 diabetics, you notice just inherently due to their insulin resistance, they have much higher doses being required. So it's maybe starting at 0.7 units per kilo per day, all the way up to 2.5 units per kilo today. And that can go up even higher. Like you can have astronomical doses of insulin being used for some of these type 2 diabetics who have consistently poor diets and have a huge amount of insulin resistance. So it can be pretty difficult to manage some of those patients when they have such large volumes of insulin that are needed. When you're doing these regimens, typically you want to break up your doses as 50-50. So you want to do 50 as basal dose or your long-acting insulin. So you take that 0.5 units per kilo per day, say for a type 1 diabetic. 0.25 of that would end up being for long-acting insulin. And then the other 50% would be bolus or of regular or rapid-acting insulin to cover mealtime doses. Okay, so just an example. Say you had a 40 kilogram female who's diagnosed with type 1 diabetes. We'll say that her total insulin dose per day will start off with 0.5 units per kilo per day times her weight at 40 kilograms. And you say, okay, she needs 20 units per day. Okay, seems pretty reasonable. You would end up, let's say, go ahead and split up her dose as the basal. 50% of that would be basal, so 10 units per day will be that. Now, insulin Detamir you don't normally give twice a day, but just for a reference here, just to show you a different way that you could dose some of these insulins, you could break that up. So you could do 5 units of insulin Detamir subcutaneously once in the morning, once in the evening. and then the other 50% would be for your mealtime coverage. And so this is a pretty typical way to break it up, where you get 20%, a little extra boost in the morning, just because you've had a long period of time without eating or without insulin, and so it kind of gets you kind of back into the swing of things. And then the other 15% at lunchtime and dinner time. So obviously that will be modified based on how the patient responds to it. So this is just initial dosing based on their insulin resistance and their the method of covering mealtime coverage, whether it be a sliding scale or whether it be carb counting, can change pretty variably. So just be aware of that. They're all going to be snowflakes. They're all going to be a little different from one another, and as far as what their insulin dosing regimen will ultimately end up being. So as I mentioned, with the pumps, they can provide basal and bolus dosing of insulin throughout that day, but they require the patients to really input their mealtime carbs and to calculate a bolus dose. It requires a lot of attention to detail. This is why I mentioned that it's not an actual pancreas. It's very easy for patients to goof it up and get hypoglycemic or hyperglycemic if they're not careful with it. So this is really meant for just patients who are well controlled on subcutaneous dosing beforehand. They get really good training. There's lots of awesome diabetes counselors out there that can help patients get started on this. And just keep in mind, these pumps are not perfect. You can have malfunctions, which can lead to either extremes of glucose in high values or low values. And so this could be a possible reason for admission for some of these patients. So I've already alluded to, hypoglycemia is the biggest complication that you can see with insulin and the most likely to be life-threatening, okay? So patients really have to be educated on the signs and symptoms of hypoglycemia, okay? If not, then that could be really problematic. They can end up having severe hypoglycemia, which can lead to coma, can lead to seizures, can lead to death. So they really need to be educated well on this, okay? You can have some patients, especially if they are kind of long-standing diabetics with lots of insulin resistance, you can actually end up having these kind of neuropathies that occur that actually end up blunting this response. And so for some patients, you might actually see this hypoglycemic unawareness. So if they have really frequent episodes of hypoglycemia, if they have really poor controlled diabetes, you can end up seeing this unawareness. But it's probably going to be for more kind of experienced patients. So blood glucose, we will consider to be hypoglycemia if you're less than 65, say, to 70 milligrams per deciliter, depending on where you work and what their definitions are. And a lot of times patients tend to overcorrect on this. I'm sure you've experienced this if you ever become hypoglycemic. You get really shaky and sweaty and you feel really, really terrible and you're just like, I just got to eat something. And so they end up overcorrecting and basically eating everything in sight. Then that leads to hyperglycemia, right? So that's not the ideal thing we'd like to do. And so oftentimes patients are educated on the rule of 15, which is a good way to manage hypoglycemia. So if they are hypoglycemic, they would say, okay, let's do 15 grams of simple carbohydrates. You can find this in 8 ounces of orange juice, 8 ounces of milk is fine, or if they have glucose tablets, 4 of those equals about 15 grams of carbohydrates. Again, these are simple carbohydrates. These are things that the body can break down really easily. Something like complex carbohydrates like oatmeal or wheat bread or things like that, they don't get broken down quite so quickly. So you want fast-acting carbohydrates. Okay, some patients will have glucose gels they'll have available to them that they can ingest, and we'll get basically the same thing done. Okay. So they'll get 15 grams of carbohydrates. They will check their glucose in 15 minutes to see how they've responded. And if they're still less than 70 milligrams per deciliter, then they would go ahead and repeat that. Okay. This is assuming your patient is coherent and awake and is able to tolerate this. Okay. You're going to find that some patients with severe hypoglycemia may not be able to be compliant with this type of therapy. So if a patient is unconscious or unable to manage their hypoglycemia, there's a couple different options we have in order to help raise this. First one is that frequently patients will be given as needed or PRN doses of glucagon that they can fill at the pharmacy and take home with them. Okay, so glucagon is a natural product that your body normally secretes. Basically, when injected, this is also given either by IM or sub-Q injections, this actually stimulates glycogenolysis, causes the liver to start to break down glycogen, and will cause gluconeogenesis to occur to raise the blood glucose. Okay. One other place you might see glucagon being used is that it can actually help to lead to smooth muscle relaxation in the GI tract. So sometimes if we have a kid who's ingested a foreign body that's stuck in the esophagus, you can actually try to use that to loosen that up and have it pass. And I kind of mentioned this in class previously, I believe. But anyway, if a patient's been hypoglycemic for a long time, you're going to find that they deplete themselves of glycogen stores relatively quickly. And so in some cases, you may give glucagon, and it may not actually work for that patient. So this is where you might need to go down to your next therapy. Biggest adverse effect you're going to see with glucagon is nausea and vomiting. So just be aware that that's going to be a notable side effect. You may need to give them some ondansetron or something like that to help deal with that. Notice here that it's you can see the kit up here on the right. It is an injectable only, and it comes as a freeze-dried powder. So it has to be reconstituted. So it's really important to educate patients on how to do this. You can see here that the syringe already kind of comes pre-filled with a diluent to solubilize that glucagon. So essentially, they would end up injecting that fluid into the vial. They would end up kind of slowly kind of shaking. You don't want to shake it up specifically because it can cause foaming and cause the protein to denature. But kind of slowly swirling, rolling it is able to put it back into solution. The patient draws that back up and then goes ahead and injects it, usually intramuscularly. And that does a pretty good job at raising blood glucose. But ultimately, if that's not going to work, we use IV dextrose. Okay, so if a patient is obtunded, if they are not able to tolerate PO, glucose, this is the way we have to go. Okay, so we give IV dextrose. There's lots of concentrations that are available out there. D10, D25, D50. Usually if you go to a hospital crash cart, they usually have D50 there for adult patients, and say D25 for your infants and pediatric patients. Just be aware the concentrations are different, and thus your volumes are going to be different as far as how much you're going to give to treat that patient's hypoglycemia. I'm not going to get super in depth on the differences between these and what the actual fluid doses are. Just be aware that they're different. So your dose of D50, which is 50% dextrose, which means there's 50 grams per 100 ml, is twice as concentrated as your D25. So you would have to give half as much volume of the D50 as you would for a dose of D25. So just keep those kind of things in mind and make sure that you're dosing your volume based off the right concentration. Usually, for most patients, you would give anywhere between 0.5 and 1 gram per kilogram of dextrose. Usually, that ends up being around 25 grams or so. So that actually works out nicely because those vials of D50 that come in the crash cart are 50 mLs, and so it already comes with 25 grams in that. So usually, that's kind of what if you ever hear someone say, "Give me a D50," that's usually what they're trying to do is give 25 grams of glucose there. Be careful if you give high concentrations of glucose or dextrose into a vein, especially if you try to use D50 in a peripheral vein in a small child. It's very, very harsh on the veins. It can cause thrombophlebitis. You can see tissue necrosis. Just be aware of that. That's why we usually use lower concentrations for our peds patients. So, what are our goals when we are treating patients for diabetes? You'll see that the ADA, or the American Diabetes Association, will have a little bit different goals than, say, the colleges of endocrinology that are out there. So I kind of listed both just for an example there. You'll find that, your institution or what guidelines you follow may differ based on, who your provider is. So you'll kind of learn what is going to be best or what is best practice at your institution. So for instance, for the ADA, you shoot for an A1C goal less than 7%, which again, A1C is just that kind of average running 3-month glucose levels for your patients. And then they have preprandial and postprandial glucose goals as well. So, say for preprandial, anywhere between 80 to 130. For postprandial, less than 180 is usually considered at goal. Okay, if you're missing any one of these, then you probably need some changes to your regimens. You see here that for the American College of Endocrinologists, their goals are a little bit tighter, right? So they're looking at A1C, say less than 6.5, tighter, preprandial of less than 110, postprandial less than 140. So it just depends on who you end up following as what your goals are going to be for your patients. So we know that for treating type 1 diabetes, because they have a absolute lack of insulin, the treatment is going to be with insulin. So we can't really get away from that. But for type 2 diabetics, things would be a little different. So obviously, lifestyle changes would be the number one thing that they can do to help fix their diabetes. And then we're going to look at drug therapy. Normally, you want to start with monotherapy. We'll talk about kind of the go-to drug for that. And then if monotherapy is failing, then you'd use combination therapies of multiple oral drugs. And then if that's not working, then you have to start looking at a combination of oral drugs plus insulin therapy. So typically for your type 2 diabetics, just because we'd like to hold off on insulin as much as possible, that's why you see that being initiated so late in the game versus the oral drugs, which we go to, just because it's easier for the patient to be compliant with, and you have more likelihood for success. So I include this slide because I think it's pretty a good illustration of kind of what's going on with the type 2 diabetic. If you're looking at someone who has normal glucose tolerance, which is this blue line here, impaired glucose tolerance, which is kind of that pre-diabetic kind of stage, and then type 2 diabetes. If you look at their plasma glucose levels, you can obviously see that, looking at around a mealtime bolus right here. So you'll see that the people with impaired glucose tolerance, they don't really have as good of a drop back in their glucose as you would have if you had normal glucose tolerance, meaning that these people with impaired glucose tolerance have more insulin resistance, right? So they don't really respond as well to spikes in insulin. Versus your patients with type 2 diabetes, they already have a higher baseline level of glucose already, and then their increases are going to be even higher than you'd see with the impaired glucose tolerance, right? So you would expect that based on what you know about type 2 diabetes already. But also looking at the insulin levels, this is pretty interesting as well. With the normal glucose tolerance, the blue line here, you see kind of a spike in response to the carbohydrates, but then it drops off pretty quickly afterwards. Versus with the impaired glucose tolerance, you kind of need higher levels of insulin in order to help drive that glucose into the cells to have it come back down to a normal glucose. So you end up having higher levels of insulin being released for longer periods of time. This is obviously puts more strain on the beta cells and can wear them out more quickly. And that's why you see in type 2 diabetics, when they actually get to that point, the beta cells are kind of tired. They're kind of done of kicking out all that insulin. And so you may actually see a relative deficiency of insulin, even though they're still very insulin resistant. They need more insulin, but they just can't really put any more out based on the beta cell destruction and the deficiencies they have there, right? So you're going to see that kind of the two big things that we can do to help fix our type 2 diabetics is to, one, restore that insulin sensitivity, and then two, to make more insulin. Okay, so those are kind of the two ways we're going to be doing that, and you'll see how our drugs are going to be affecting that specifically. So another thing you see with these type 2 diabetics is the fact that they can't really regulate their glucagon quite as well as a person with normal glucose tolerance. And so we mentioned glucagon already as being a hormone that helps to stimulate gluconeogenesis and glycogenolysis in the liver. And normally after mealtime, you really don't need a lot of glucagon, right? Your glucose levels are already higher anyway. So if you would look again at the insulin release of a patient with normal glucose tolerance in the green here versus type 2 diabetes, again, they're not really spitting out as much insulin. And normally insulin has an inhibitory effect on glucagon secretion, right? If you have enough insulin around, that usually is a good sign that there's a lot of blood glucose. You probably don't need a lot of glucagon, right? So here we're looking at the glucagon secretion, right? 0 time being the time that carbohydrates are administered. You can see that for the glucagon for the patients with normal glucose tolerance, they'll have kind of a higher level here, kind of at rest, and then once they have that stimulation of the carbohydrates, that drops down pretty precipitously, right? Because they don't need that because they already have a lot of blood sugar from the carbohydrates they ingested. Versus a type 2 diabetic who has that lack of insulin, you end up seeing higher levels of glucagon in general, which is also driving up their blood glucose. So you're going to see some drugs that can actually help to blunt this response and help to drive glucagon levels down, which will also help maintain good control of our blood sugar. So here are the major classes of oral medications we're going to use to be treating our type 2 diabetics. So the first one, these will be our Sulfonylureas and Meglitinides. These are two classes of meds that work very similarly. They help to stimulate the pancreas to make more insulin. Okay, so that's one way we can do things. We'll have our Thiazolidinediones. These can be abbreviated to TZDs. Those are also being known as the glitazones. And you also have the Biguanides. And so these are going to be drugs that sensitize the body to insulin or help to control the hepatic glucose production. Okay, so those are kind of the two main things we already talked about. Either help the body to use insulin better or to make more insulin. We'll have a small group of drugs that help to slow absorption of carbohydrates and starches. That'll be our Alpha-Glucosidase Inhibitors. And then we're going to have some other drugs that are going to be glucagon-like peptides. These are called our Incretins, and they actually help to suppress glucagon. They help to slow gastric emptying, and they also help to increase satiety, meaning that you're not hungry as much, and so that helps to decrease food intake. And then the newest class that we have is actually ones that decrease the reabsorption of glucose from the renal tubules, so that you basically just pee out glucose, and those will be our SLGT2 inhibitors. So we're going to talk more about these in detail as we move forward. This is a slide. It's a little bit older because it doesn't include some of the newer classes, but just to give you a relative idea of the reduction in fasting plasma glucose and then also A1C reduction, you can see that for the most part, a lot of these are equally efficacious. You probably see the most benefit out of things like your Biguanides, your Sulfonylureas, and the Thiazolidinediones. The Meglitinides and the Alpha-Glucosidase Inhibitors probably are used less frequently. And so we'll talk about some of the limitations of those products and why they don't get used very often. Okay, so we'll have our sulfonylureas. These are going to be divided into some of our first generation and second generations. You'll see that chlorpropamide is the only one I've bolded here. That's really the only one you might see out in clinical practice. So, as far as coming up on tests, probably the ones I've bolded here are going to be the ones that are going to be most likely to show up. The second generation ones are a lot more potent, and you also see less side effects from these drugs. And so glimepiride, glipizide, and glyburide are the main ones you see being here. Probably glyburide and glipizide are the ones I see most commonly in clinical practice. So all three of these you should know as well. How do these drugs work? So we already kind of mentioned how insulin gets released from the beta cells within the pancreas, but just for a brief recap, if you're looking here, whenever you have glucose entering into the cell, again, this is a beta cell within the pancreas, glucose comes in, gets metabolized into ATP, right? That's high energy. That's going to end up closing off these potassium efflux pumps, right? So potassium starts to build up here within the cell. That's going to trigger a depolarization of the cell. So you have a membrane depolarization, and that ends up opening up this voltage-gated calcium channel. Calcium flows in and stimulates these secretory granules, these vesicles, to release insulin out into the bloodstream. So how do we use the sulfonylureas to help stimulate insulin release from the pancreas? Well, we can go ahead and use these drugs to block that ATP-dependent potassium channel, right? So by blocking this channel specifically, you end up having more depolarizations, more calcium coming in, and more insulin being released. Okay, so ultimately, what you're going to see is you're going to have less basal hepatic glucose production, less gluconeogenesis and glycogenolysis, basically because the insulin being released tells the liver, hey, we have enough glucose, we don't have to release anymore, go ahead and stop what you're doing, right? You may see some small increase in insulin receptor sensitivity in the number of receptors that are being expressed, so that can be another good thing. And then also because insulin is kind of diegetically opposed to glucagon, you'll see decreased glucagon levels as well. Okay, somatostatin can also have some effect here, but mostly it's going to be insulin that's the main thing you see being affected here. Okay, so all these things are good for our patients, and all these are going to help maintain a better, tighter control of our blood glucose. All of these are going to be extensively metabolized in the liver. Some may have some active metabolites which help extend their duration of action. A lot of them get excreted in the urine. Remember, you mentioned that a lot of insulin gets released in the urine as well. So if you have poor kidney function, that can also kind of increase the duration of action of these drugs because the insulin just sticks around for longer. You may see some issues with this in your diabetic mothers, so you don't want to use this. This is why insulin is really the preferred drug for those patients, because you can actually have the fetal pancreas being depleted of insulin as well. So probably not use this in your pregnant patients. I mentioned chlorpropamide being that first generation agent. You probably don't want to use this one in elderly patients. It's a very long duration of action, about 48 hours or so, and probably has the highest side effects profile, right? So hypoglycemia is going to be the big side effect we'll mention here in just a minute. Also, very similar to something like metronidazole or Flagyl, you have a disulfiram reaction that can occur when you ingest this with alcohol. So, clinically, when you're looking at this, chlorpropamide and glyburide are the most common ones to cause hypoglycemia. So those are most likely the ones to be problematic for your patients, which is why you see a lot more glipizide probably being used out there in the clinical world. So glimepiride may actually help to enhance the sensitivity of peripheral tissues to insulin, so that can help with some of that insulin sensitivity problem that we know we have with our type 2 diabetics. And you see with the drugs, if you use them in combination with exogenous insulin, it may end up decreasing the total dose they need as well, right? So it kind of depends on what stage the patient is in, how kind of depleted their beta cells really are upon initiation of this. Again, with all the sulfonylureas, you're going to have a pretty rapid control of the glucose, but the biggest risk will be hypoglycemia. Glyburide is long-acting, used as once daily dosing, which is pretty handy. This one, again, you're going to have the most frequent hypoglycemia associated with that one, so that can be problematic. Glipizide, probably the one that I see most commonly. Glucotrol XL, which is an extended release formulation, which provides kind of once daily dosing as well. You end up seeing a shorter half-life of this one and also less hypoglycemia, which is probably why it's so popular. They do recommend taking it 30 minutes before meals because basically that's when your pancreas is going to be most active anyway, is when you have carbohydrate intake. This becomes more important for our Meglitinides, but you'll see that this one works a little bit better if given before meals. Hypoglycemia is going to be the biggest side effect we worry about with these drugs, especially patients who maybe are having kind of erratic food intake. This can be problematic for them. So be aware of the hypoglycemia. Anytime you're increasing insulin releases while weight gain is going to be a problem. Okay, just like we saw with exogenous insulin, the same thing can happen with this. All right. Other than that, they're pretty well tolerated. You may see some of these kind of one-off side effects every once in a while, but for the most part, very well tolerated. Just really the hypoglycemia is the biggest risk. You may see resistance develop over time to this, and this is mainly just due to the beta cells getting more worn out. They're getting used more frequently due to this kind of added pressure from the sulfonylureas to release more insulin, so that can lead to resistance over time. So you may find these drugs are very useful early on in the management of your patient's diabetes, but they get less and less so as they get more kind of progressive in their disease. As far as contraindications go, it's always important to remember that when you're treating diabetic ketoacidosis, which again is that kind of condition for more so with type 1 diabetics, where they are dealing with a severe lack of insulin, they get very hyperglycemic, and their cells basically are just not able to really process glucose appropriately because they can't get any glucose into the cells. While you may think, well, sulfonylureas can increase insulin release, that should fix the problem. You don't really want to treat DKA with that. Really, exogenous regular insulin is going to be the best thing to treat those patients. Okay. Also, these drugs will not do anything for type 1 diabetics, especially if they have kind of complete lack of beta cell function. They're not going to get any benefit from this. So you wouldn't want to use it for those patients. And again, we mentioned avoiding this in pregnancy and breastfeeding, since that can deplete fetal levels of insulin. As far as interactions go, obviously anything that increases blood glucose can decrease the effectiveness of this. Anything that is causing hypoglycemia, so anything else that would cause insulin to be increased release, or anything that would block gluconeogenesis in the liver, anything like that could also enhance the hypoglycemic effects as well. I mentioned the disulfiram-like reactions with chloropropamide, and then because these are all highly protein bound, if you did have something come along and were to compete for that protein binding, you can end up seeing increased activity, more insulin being released, and more risk for hypoglycemia. The drugs that act very similar to the sulfonylureas are going to be your Meglitinides. Clinically, I don't ever really see these being used, but again, I don't deal every day with adult diabetic patients, so your mileage may vary with that one, but at least for completeness sake, be aware of these drugs. There's two of them. They're called Repaglinide and Integlinide. They work identically to the sulfonylureas, but the only big difference with these guys is that the insulin release is only relative to the glucose level. What I mean by that is, if you take these drugs when there is no kind of stimulatory glucose increase due to food intake, they don't really cause the pancreas to really release a whole lot of extra insulin. Okay, pretty useless in that case. You do want to take these around mealtime, because when you have mealtime increases in blood glucose, that will also help to stimulate the pancreas to increase insulin release, and that will help these drugs to work better. So really, these have to be taken along with mealtimes, otherwise they're not really going to be very effective. Very similar to things you would see with the sulfonylureas. They're highly protein bound, they have hepatic metabolism, but again, keep in mind that you're going to be taking these drugs before meals to make sure they're effective. And so the other important counseling point is that if you miss a meal, you want to go ahead and skip a dose of this, because otherwise you're not really going to get a whole lot of benefit from it. Okay. Typically, you don't see these mixed with a whole lot of other oral agents. You wouldn't want to use a Meglitinide plus a sulfonylurea because their mechanisms are too similar. But one thing you will see is that a lot of these drugs get mixed with metformin. We'll talk about why that is in just a little bit. So the adverse effects are going to be very similar to what you would see with the sulfonylureas, so hypoglycemia, weight gain being the biggest ones, and then maybe some small risk for things like headache, nausea, kind of non-specific issues. Okay, so this is one of the big groups of drugs we're going to be using for a lot of our type 2 diabetics. This is probably going to be the first drug that you're going to use for most of your type 2 diabetics. And these are called the Biguanides. The main one that we see being used here is called metformin, right? So that's why it's the only one that's being bolded there. You have buformin that's used in Europe and fenformin. We don't really use that one anymore due to risk of fatal lactic acidosis, but we have metformin. And so you'll see this come as XL formulations a lot of times to help increase the duration of activity. And you see this very frequently mixed with other medications as well. So mixing metformin with glyburide, glipizide, rosiglitazone, all kinds of other diabetic drugs usually get mixed with metformin in order to help decrease the pill burden that these patients are having to take. So how does metformin work? Mainly, this is an insulin sensitizer. It does nothing to increase insulin release. It just helps your body to use insulin better, okay? So by working on the liver, you're going to see decreased glucose production coming out of there, right? So that'll help to lower blood glucose. This will also help to increase peripheral glucose uptake and to utilize it more effectively. So that's that increase in the insulin sensitivity we mentioned. And also, it's going to limit the amount of glucose being absorbed from the GI tract. So 3 main ways that this is helping to work, and this really helps to limit that hypoglycemia. So you really don't see a lot of hypoglycemia with the biguanides. Also, you're not going to see a whole lot of weight gain with these drugs. And in fact, if anything, you may see a little bit of weight loss with this versus something like a sulfonylurea. This drug is not metabolized in the liver, but it does get a contraindication for hepatic disease because normally you're processing things like lactic acid through the liver, and so if you have bad hepatic disease, you may not be able to process the lactic acid, which can lead to lactic acidosis, which is not good. The big thing you want to watch out for is kidney function. These get excreted unchanged in the kidneys, and so if you have poor kidney function, you're going to have a buildup of the drug, and that can lead to that lactic acidosis. So be very, very aware of that. Okay, this is great for patients who are already obese or already have a significant amount of insulin resistance, because this is going to be useful for all those cases. Okay. The biggest side effects you're going to see with the biguanides is the GI effects. So you can have kind of unpleasant kind of metallic taste. You will see nausea, vomiting, diarrhea associated with this one. So be aware of that. The other big thing you want to worry about is that lactic acidosis, mainly in patients with poor renal function. You may see this patients who are, say put on this drug early on in their diabetes and stay on it for decades, and you don't really reassess their kidney function. That can be problematic. Or say after surgery or anything where you're having acute volume changes in the body leading to hyperperfusion of the kidneys. All of that can lead to some big risk. Okay. Other things you might see occasionally will be maybe some rash and also this megaloblastic anemia due to B12 absorption being inhibited. I'm not really sure the mechanism for that, but you may need to supplement extra with, say multivitamin or something for your patients. So as I mentioned, the renal disease issue, if they have a creatinine clearance less than 30 mLs per minute, do not use this drug. It's contraindicated, okay? They used to have old recommendations based on the serum creatinine value of a patient, so say like 1.4 for females, 1.5 for guys, but that's not really the case anymore. So if the GFR is less than 30, do not use this drug, okay? If they are already acidotic, do not use this drug. If they are having any kind of competition for tubular excretion, meaning that you would inhibit their renal release, don't use it as well. Okay. So typically what we do, especially for cases of surgery, is you go ahead and withhold the drug for about 48 hours after the surgery due to that increased lactic acid risk, and then you can reinitiate it. Okay, this is not going to be a big deal if you stop it for a few days. They may have some hyperglycemia, but it's not going to be as kind of detrimental as if you were stopping a type 1 diabetic from their insulin. Okay, this is okay to stop for a few days. Okay, so you have, sulfonylureas, you have metformin. Both of those are going to be kind of your mainstays of therapy for type 2 diabetics. And now we're going to run in some other drugs, which are going to be good supplemental drugs in order to help manage these patients. So next up, we have the Thiazolidinediones. You can call these the TZDs, which is how they're most often referred to, or the glitazones. That's how I hear a lot of people call this as well. There used to be 3 of them. There's troglitazone, but that actually got removed from the market due to liver toxicity. And so nowadays we have PO and Rosiglitazone, so Actos and Avandia. The way that these drugs work is that they are agonists for this peroxisome proliferator, activated receptor gamma, or PPAR gamma. Okay, what does that mean? Well, basically that is a product that regulates transcription of insulin responsive genes. So if I agonize that, I increase transcription of those genes, and thus I'm going to have better effects on lipid and glucose metabolism. So similar to metformin, you're going to see that these drugs increase insulin sensitivity because they help to increase peripheral glucose uptake and utilization. They decrease the hepatic glucose production as well. This is a correction on your slides. It probably says decrease hepatic insulin production. Obviously, the liver does not produce insulin. So, and then notice that because it affects gene transcription, it takes time for this to work. So maybe 6 to 12 weeks before you really see maximal effect for these drugs. As far as adverse effects go, you do worry about this drugs with patients with heart failure. You can see expanded blood volume and edema. So they already have kind of advanced heart failure or it's not well controlled. You may see some issues with that, right? Other than that, you will see some kind of variable effects on things like the lipids. So you may have some issues with like HDL, LDL, or triglycerides, which can be kind of unpredictable. You see some weight gain potentially, not as bad as a sulfonylurea or insulin, but you may see a little bit of weight gain associated with these drugs. And then you also want to monitor for liver function. So typically they recommend, say, every 2 months for the first year. And then if you see any increase in ALT above 3 times the normal, stop the drug altogether. This is mainly from that risk that they saw with Troglitazone. I don't really see a lot of people have issues with this from Rosi or Pioglitazone, but because that one was taken from the market for liver issues, there is some thought to be risk here as well. So one of the big things you'll hear about is that the TZDs or the glitazones cause increased risk of cardiovascular death. This has really been the case with Rosiglitazone more than anything. So there's a lot of studies out there that were looking at potential cardiovascular issues. And one of the things that they saw is that if you look at, I know I have not covered biostatistics with you guys, so you'll probably get that in another class. But one of the things that we're looking at is Rosiglitazone and the risk for myocardial infarction. So you see overall, if you combine all these trials together, even though that the individual trial showed no kind of individual risk for Rosiglitazone causing increased myocardial infarction, when they kind of pulled all the data together, there was an increased risk here that was significant. So about 43% increase in your risk for developing or increasing your odds for developing a myocardial infarction. Very similarly, you saw this in small trials combined or overall death from other cardiovascular causes as well. So that's why you see a lot of commercials about lawyers and saying that, if you or a loved one have taken Rosiglitazone, you may be entitled to money, blah, blah, blah. A lot of that is due to some of these trials saying that there could be risk for increased cardiovascular death. So as far as I know, I don't think that I've seen any increased risk with Pioglitazone, so that may be the safer one to use if you chose to go down the route of using a TZD for some of your patients. Okay, the next group we'll talk about are our Alpha-Glucosidase Inhibitors. Two ones in this group are called acarbose and Meglitol. These actually work as competitive inhibitors for this alpha amylase and alpha-glucosidase enzymes in the GI tract. Specifically in that intestinal brush border. So basically, these decrease glucose absorption. Okay, so less glucose getting in through the GI tract, less of it gets to the bloodstream, thus you're going to have lower blood glucose levels. These drugs are nice because they're actually not being absorbed from the GI tract. With Meglitol, you may have a little bit of absorption, but for the most part, you don't really see any kind of systemic side effects from these. Okay, these only work if you take them with the first bite of each meal, right? Because that way you have carbohydrates to actually block from getting absorbed in the first place. Usually you do not see these used as monotherapy. These are typically added on with other oral agents or with insulin as well. The side effects are usually the big thing that limits the utility of these drugs. You see a lot of abdominal pain, a lot of cramping, a lot of diarrhea, and then the flatulence is huge for these patients. Because again, if you are not digesting your carbohydrates, the bacteria in your colon certainly will, and that produces a lot of gas. So a lot of patients don't like this, and this is why you don't see a ton of use for this. And so obviously, if you have any issues with inflammatory bowel disease, chronic intestinal disease of any kind, these are going to be contraindicated just because you can worsen that potentially. Next up, we want to take a look at the incretins. These are products that are intrinsically involved with glucose homeostasis and insulin in patients. And so one of the things that you see is that incretin is a product that is released especially during mealtime increases in glucose. So for instance, here's a study that was looking at oral versus IV glucose ingestion or administration, and looking at the incretin changes as well. So for instance, if I were to give oral glucose and IV glucose, you would see changes in blood sugar that can be almost identical, right? The big change here, though, is that only with the oral glucose did you see an increase in this product called incretin. Okay, didn't work when you saw increased levels of glucose in response to IV administration, only the oral. This is going to be important for dealing with mealtime increases in glucose, and we're going to have drugs that actually work to either mimic this effect of incretin or will actually help to make it last longer. So we'll look at some of that in just a second here. The main incretin that we're going to be concerned with is this glucagon-like peptide 1, or GLP-1, as you'll see it being referred to frequently. You'll see that after mealtime glucose, usually when your blood glucose rises above 90 milligrams per deciliter, this will stimulate release from these L cells of the intestine. Okay. Once GLP-1 is being released, what you're going to see is that it will help to increase glucose-dependent insulin release from the pancreas, which is good. You're also going to see decreased gastric emptying and food intake, right? Because this will help to stimulate satiety, meaning your patients feel full, they don't want to eat anymore, okay? You also see this will have effects on the transcription of insulin as well. So GLP-1 is typically you're going to see being reduced in patients with type 2 diabetes over time. And also the big thing to note here as well is that it's metabolized by this enzyme called dipeptidyl peptidase 4, DPP4. That's important because one of our drugs we're going to look at actually inhibits this process. So as I mentioned, lots of different things that the incretins or GLP-1 is going to be doing for us. So again, secreted upon ingestion of food, helps with insulin secretion here, helps to regulate gastric emptying time. You're going to see the liver make less glucagon, which is going to be good here. And then you're also going to be having the brain. It's going to help promote satiety and reduce the appetite. So patients are going to feel fuller. They're not going to want to keep ingesting food past what they really would need otherwise. So again, type 2 diabetics are going to have diminished levels of insulin. Not only that, but also post-prandial GLP-1 induced insulin secretion as well, right? Again, it could be a lot of it due to insulin resistance and things like that. You also find, especially on that slide we saw previously, that type 2 diabetics have increased glucagon levels after meals anyway. So if we can increase the activity of GLP-1, that will help to suppress glucagon levels after a meal. It will also help to decrease that glucagon increase during the fasting time periods, and also glucagon-dependent glucose production. So really it's kind of helping us throughout the process here. So increases insulin release, decreases glucagon, all good things for our type 2 diabetic patients. So this will also help to slow the gastric emptying time, which will slow peak glucose absorption, which can also help kind of lead to less high peaks of glucose intake, and again, it will help to increase satiety. So hopefully overall your patient is ingesting less carbohydrates. So again, we looked at the slide previously. You can see how glucagon levels are just going to be elevated in patients who have type 2 diabetes versus those with normal glucose tolerance. And then looking at this slide, this is a newer one where patients are basically you see levels of GLP-1 in the bloodstream and they're eating breakfast here at this time point. Notice that the type 2 diabetics in the red line are going to have greatly diminished levels of GLP-1 versus those that have normal glucose tolerance. So if we can do anything to help increase the half-life of GLP-1 or to directly agonize the same receptors that GLP-1 does, that'll have positive effects. So the first drug that we had that was an incretin mimetic, as you'll see these drugs called because they mimic the effect of incretin or GLP-1, it was Exenatide. The brand name is Byetta there. And so I have a picture of a Gila monster here because this is actually where we isolated this product for the first time. So again, very similar to where I have no idea why scientists decide to check out salmon sperm for things like protamine or calcitonin. We do find that someone decided to check out the spit of a Gila monster and found that, hey, this product is pretty similar to GLP-1. It's about 53% homology, right? So we can use that for our patients. We can use it in combination with things like metformin and sulfonylureas. That's not controlled by that alone. And so you can also sometimes see some good effects on weight loss. We mentioned, if the patient does not feel hungry, hopefully they're intaking fewer calories. And so you have positive effects on the weight loss. The only problem with these incretins is because they are protein-based products, right? Because they're trying to mimic the GLP-1 that your body would normally release. They have to be given subcutaneously. Okay, they cannot be given orally. So, for instance, with Byetta, that was the first product we had here. You would inject it, say 60 minutes before meals to try to stimulate how GLP-1 would be released normally in the body, and you do it. As a pre-filled pen injector, basically, and it had a relatively short half-life. So patients were having to give themselves multiple injections every single week, and it was kind of problematic. So that'll be one of the problems that some of the later incretins try to overcome. So just to give you an example of how Exenatide or Byetta is really kind of helping out this process. If you're looking here, you have insulin release, insulin levels here in the bloodstream, and looking at glucose administration. You can see with a healthy control patient who has no glucose or insulin tolerance, you can see that levels of insulin kind of spike up and then drop back down. Okay. If you were to look at someone who had impaired glucose tolerance and type 2 diabetes, the blue line is going to be placebo, where you see spikes in insulin. Notice how it's being diminished. But if you were to give Exenatide or Byetta, you do see a lot larger spike in the insulin being released, right? It kind of starts to mimic what you normally would see in someone with no glucose or insulin resistance. Okay, so really we're just trying to help to mimic what would normally happen in the body by helping to increase activity of these incretins. So other things we're going to be seeing, nausea, vomiting is going to be increased, basically due to this increased decreased gastric emptying time. So if things are sticking around the stomach for longer, you're more likely to have that come back up. Usually patients get tolerant to this over time, so it's not going to be a big issue if they kind of stick with it. Okay. You do see some small risk for hypoglycemia by themselves, but it's going to be more pronounced if they have sulfonylureas on board because they are also kicking out their own insulin as well. These can also delay the absorption of other oral medications due to that decreased gastric emptying time. And then you will see, weight loss associated with this, which can be a great thing. And then the other big issue you run into with all of these incretins is going to be pancreatitis, right? So it's kind of a unique side effect that you see with this one that will be not something you see very frequently otherwise, but just be aware of this kind of a unique side effect for this class of drugs. So we have a few other ones that are have a longer half-life, which is fortunate because you're going to see they have to be given less frequently. So we have like liraglutide, dulaglutide, and Meglitinides. So again, they are all going to be similar to GLP-1, trying to be an analog of that. See, for instance, something like Victoza or liraglutide gets bound to albumin. So it's given subcutaneously, it's bound to albumin, and it has a slower release to it, so it has to be given less frequently. Some of the other ones that can be administered, once weekly subcutaneously. So it's going to be a lot better for your patient. Byetta, you're injecting at least once or twice every single day. If patients can just use once weekly injection, it's going to be a lot better for them. The other way that we can enhance the effect of GLP-1 is to inhibit the dipeptidyl peptidase 4, or DPP4, right? This peptidase is involved in that breakdown of GLP-1, as well as some other peptides, including things like growth hormone and whatnot. Also, interestingly enough, is involved in some T cell activation through CD26. So clinically, who knows what kind of that's going to help with, but it is another activity that this DPP4 has. So we have a few inhibitors of this. We have the gliptins. So you have things like Sitagliptin, Saxagliptin, Linagliptin, Logliptin. All of those are working to inhibit DPP4 and will increase the activity of the GLP-1 that your patient may be releasing already. Okay. Do run some risk of things like anaphylaxis, some skin rash reactions. So just be aware of that. It's pretty rare that this would occur. Otherwise, they are tolerated pretty well for the most part. You see here, if you were to give, there's some kind of beneficial effects to giving multiple meds at the same time. As here, there's some synergism if you were to give something like sitagliptin plus metformin versus either drug by themselves. So you can kind of see some benefit there in that green line. So frequently you don't see the gliptins being used by themselves, but oftentimes in combination with other ones. And we'll talk about that stepwise approach and how you would go about treating your patients with type 2 diabetes. So there's a few things I kind of want to take you for you to take away from this comparison between the GLP-1 activators and the DPP-4 inhibitors, right? So again, both of them are going to have good effects on insulin secretion and will have ability to reduce glucagon. But the big thing to note is that with the GLP-1 agonists, you're going to have a lot better effects on things like satiety, gastric emptying. That's why you're going to see a lot more weight loss with these drugs, right, than you with the DPP-4 inhibitors. But you're also going to see more GI side effects. Okay, so for instance, the DPP-4 inhibitors may be better to combine with something like metformin, because we already know metformin has a lot of GI side effects associated with it. So keep things like that in mind. Also, because the GLP-1 agonists are protein-based products, you can have antibody formation, which may limit their utility, may lead to allergic reactions, which can be problematic. And then also these are only injectables, so less tolerable by patients in a lot of cases. If they can just take an oral med, they probably would prefer that, right? And then looking at their kind of unique safety profiles, obviously pancreatitis being a problem with the GLP-1 agonists versus Stevens-Johnson's for the DPP-4 inhibitors. So the newest class of drugs that we have for treating diabetes is the sodium glucose cotransporter 2 inhibitor, the SGLT2 inhibitors. So we have canagliflozin, we have dapagliflozin, and empagliflozin. Those are the three main ones. I think they're running out of drug names because the flozin sounds kind of silly, but regardless, you will sometimes see combination products used here as well. So again, you'll find a lot of drugs being given in combination in order to help decrease that pill burden of these patients. Okay, these are going to be inhibiting that SGLT2 transporter in the proximal renal tubule, right? And that helps to decrease the reabsorption of filtered glucose that comes through the glomerulus, which means you're going to have increased renal elimination of glucose. So it's going to come out a lot sweeter because there's a lot more glucose coming out of the urine, which is going to be very important for one of the side effects that you run into with this drug, these drugs that is unique to them. These are going to ultimately, though, lower blood glucose and also help with body weight because you're peeing out the glucose. It can't get transported into the cells to be turned into adipose tissue. Big thing you see here is urinary tract fungal infections. Okay, this can be problematic, especially if patients have other comorbidities which make them more prone to urinary tract infections. So be aware of that. You may have a patient who says, they're starting on one of these drugs and then says, okay, well, and I think I have a UTI, and you try treating with something like ciprofloxacin or say Bactrim, and come back and like, hey, it's not getting any better. You need to think fungal infections, right? You may need something like fluconazole in order to help treat that. Okay. Some other issues you can run into, you can end up seeing raising serum potassium levels, which can be problematic if patients are on things like ACE inhibitors and have renal disease. Kind of a unique thing you can see for some of these patients include bone resorption or bone fracture risk. It's kind of a unique side effect you see with canagliflozin. And then also unique to these drugs is a risk for diabetic ketoacidosis, but it's actually euglycemic. Normally, when you have a DKA patient, their blood sugar levels are very high, mainly because they have that lack of insulin that's not shuttling glucose into the cells. Here, for whatever reason, this increased blood glucose, instead of being kept in the bloodstream, it'll just get peed out in the urine, right? So you end up having these patients being euglycemic, but still having that lack of insulin, and thus you have that DKA develop anyway, right? Okay, so we're going to be looking at how we actually treat these type 2 diabetic patients based on the medications, looking at combination therapy. If you're not able to control their blood glucose, we'll look at all these things. So obviously, first off, you always want to start out with your non-pharmacologic therapy. So healthy eating, weight control, increased physical activity, all that good stuff. But that's not going to work generally unless they have a contraindication. You want to start with metformin. It's always going to be kind of the go-to first drug here. Okay, so we're going to look at the different components of these drugs to see how they play nicely with each other or not, and looking at different things like costs, like can your patient afford to be on one of these medications or not, because that will obviously affect compliance. Okay, so first off, looking at metformin, you look at your effect on decreasing the HbA1c. Very good effect here, right? This helps to make our body use the insulin better. This is going to be great for decreasing the A1c in general. Okay. Look at hypoglycemia risk, very low risk, right? Because this is not causing the liver or the pancreas to spit out more insulin. Thus, you have very low risk for hypoglycemia, which is great. Okay. As far as weight effect, you may have no weight changes, which is good for a lot of patients, or some weight loss, which is good for a lot of patients, right? Especially if you have concomitant obesity. Okay. And then side effects wise, GI effects are going to be the king here. A lot of nausea, vomiting, diarrhea, all of that. And then that risk for lactic acidosis, specifically with patients who have poor kidney function. Okay. And then also this drug is very, very cheap, especially if you use the immediate acting generic form, pennies for the pill, right? So you can get away with using that very, very cheaply for most patients. So this is really why this is great for first-time users for type 2 diabetes, because it just helps this to work, help make the insulin you're already making work even better. So, something that might come up on the exam is to ask a question of like, well, are any of these medications for type 2 diabetic, could any of them be potentially used for a type 1 diabetic, right? So you think about the mechanism of action here. So if you think about it, we mentioned that typically insulin resistance is not a problem for a type 1 diabetic early on, right? You could have patients who have kind of poor compliance issues that may develop insulin resistance, and you may end up having some patients who could actually benefit from this. It's rare, but you could have it, right? Versus something like a sulfonylurea, if you guys remember, that mechanism is to increase insulin release from the pancreas. Well, if the patients can't produce any insulin, then obviously the drug's not going to work, right? So keep that in mind. Keep in mind the mechanisms and how that interplays with what their actual pathophysiology actually is, okay? So let's say we started our patient on metformin. We are not able to reach our A1C goal, as is frequently the case. Let's see what happens when we mix these metformin with one of these other classes of drugs. Notice here that you have kind of a wide range of options. They're all going to have their pluses and minuses. So it really, there's no one guideline that says you have to add on this medication next, right? It's really going to be dependent on your patient. So first off, looking at your sulfonylurea, which is that SU. Hypoglycemia risk, efficacy in dropping the A1C is going to be very high. So this has very good ability to reduce your A1C. Hypoglycemia risk is going to be moderate risk. It's only going to be really kind of outdone by the risk with insulin. Insulin's always going to have a higher hypoglycemia risk, but sulfonylurea is going to be kind of a close second. Okay, you're going to see weight gain, which is problematic for some of your patients. And then obviously the side effects here being hypoglycemia, already mentioned that. And the cost, very, very low for the most part. A lot of these are going to come in combination with your metformin as well, which is nice for compliance purposes. Okay. Next, looking at the TZDs, or the Thiazolidinediones, which I hope you guys can all say at the end of this lecture. Also going to be good for dropping the A1C. Has low risk for hypoglycemia, which is also nice just because it's helping to increase sensitivity rather than producing more insulin. You may see a little bit of weight gain, but for the most part, I don't have that being a huge issue for a lot of patients. And then we mentioned kind of the edema effect with patients with heart failure, so be aware of that. And you find this to be a little bit more expensive. Really, the newer drugs are going to be the most expensive ones. The DPP-4 inhibitors, the GLP-1 inhibitors, especially since these are injectable products, are going to be higher price. And the SGLT2, since they're so new, are going to be the highest cost. So these are the ones that are least likely to be covered by insurance. But again, it will depend on plan-by-plan basis. Okay. Looking here, you can see that the efficacy in dropping the A1C is going to be pretty intermediate between these guys. The highest effect here you're going to see is with the GLP-1 receptor agonist, right? So those are the incretin mimetics, your Exenatides, and things like that. For the most part, pretty low risk for hypoglycemia, which is also nice. And if anything, with the SGLT2 and the GLP-1 agonist, you can see weight loss as a side effect here. It's going to be positive for some patients, okay? I mentioned some of the issues here with genital urinary tract infections, GI issues here with the GLP-1 receptor agonist. So again, you go back to your slides and kind of compare those side effects and see what's kind of best for your patient. And then obviously, if you are unable to use any of those, you could always use insulin as the next step, right? This is going to have the best ability to drop A1C, especially if you're using like carb counting or if you are doing sliding scale insulin dosing. That can be very useful. High risk for hypoglycemia, and they're definitely going to have weight gain associated with this, okay? Hypoglycemia is the biggest risk here, and then the cost can be pretty variable depending on the type of insulin that you're receiving. So regular insulin is relatively cheap comparison to something like, inhaled insulin or some of the longer-acting newer ones. So Just things to keep in mind. If you are finding that the A1C is still not in check after about 3 months or so, then you may need to look at a 3-drug regimen, right? So again, if you had, say, metformin plus a sulfonylurea, you could use a TZD or an SGLT2 inhibitor, or so you can really combine any of these therapies together, as long as the mechanisms are not identical, right? So for the most part, like if you had a GLP-1 receptor agonist, you probably don't want to mix, something like a DPP-4 inhibitor, right? For the most part, because again, those mechanisms are just too similar to one another. You don't really get any additional bang for your buck for the most part. So keep that in mind. Keep in mind what makes sense based on the mechanisms when you start to combine multiple medications together, right? And then ultimately, if they're still not having any benefit from all this, insulin is going to be the way to go, right? So always consider that, titrate your doses, make sure you're maximizing those out based on how they're tolerating it. But ultimately, insulin is going to be the end-all therapy to kind of fix their issues, right? So that's going to be it for our diabetes talk. If you have any questions, again, we'll be meeting on Wednesday. We can talk more about those. And now we're going to cover kind of some miscellaneous other endocrine concerns. First off, we're going to have hyperprolactinemia. So first, this is kind of a brief one, but usually you see hyperprolactinemia kind of secondary to these prolactin-secreting tumors, usually adenomas and things like that. Kind of problematic for a lot of patients, especially if you have things like galactorrhea or amenorrhea, impotence, infertility all pop up. So too much prolactin can really kind of put a stop to a lot of those metabolic processes. So normally what we can do is actually use treatment with a dopamine agonist. Dopamine agonism normally causes prolactin levels to decrease. This is very similar to the opposite effect you'll see when you look at drugs that we use for schizophrenia that are dopamine receptor antagonists. You're going to find that you normally have increases in prolactin levels with those drugs. We'll talk about that later, but just keep that relationship in mind that dopamine agonism drops prolactin levels. The drug we can use for this is called bromocriptine or Parladel. This is actually very similar when we talked about the ergotamines in relation to migraines. So bromocriptine is kind of in the same classification as a dihydroergotamine, right? This could also potentially be used in something like Parkinson's disease, but you would not see that used too frequently. But see a lot of nausea, vomiting associated with this, some headaches, things like that. And sometimes you may actually see it being used for inducing ovulation in patients who are known to have hyperprolactinemia. So that can be a useful thing. Another drug you may see used occasionally is called cabergoline, which is also a dopamine agonist. This one's a little bit higher affinity, but you're also going to see more issues with blood pressure and whatnot. So either of those can be useful for dropping down your prolactin levels frequently, especially if it's a prolactin-secreting tumor. You may need surgical intervention and things like that to ultimately deal with the problem. But these can be used in kind of the meantime. Next, we'll talk briefly about our androgens. We'll talk about the estrogens a lot more when we get to the OB-GYN section of the class. So again, looking at synthesis of natural steroids, you're going to see there's a lot of interplay here between natural cholesterol being either spit out by the liver or being ingested through our diet, things like that, and the process for producing other types of steroids, right? So you're going to have things like cholesterol being eventually worked on to produce things like cortisol, right? Coming from the adrenal gland, which we know is really important for regulating things like blood pressure and stress responses. You can have things like aldosterone being produced, which we know is important for blood pressure regulation and hypertension. Some of the big ones you're going to see when we're talking about OB-GYN concerns, it will have things like progesterone and estradiol. But you notice here that testosterone is the main one we're going to be focusing on right now. Notice this is a precursor to estradiol. That's going to be really important, especially when you have patients who have things like polycystic ovarian syndrome, and basically they end up having this androgenergic kind of state where they have too much testosterone floating around that's unable to be converted over to estradiol. There's different enzymes that are responsible for all of these steps, and we'll talk about those as they become important based on various disease states. So testosterone is going to be the most important androgen. Ends up getting made by the testes. Generally, men produce about 8 milligrams per day. And then the big thing that this is converted into is called dihydrotestosterone, or DHT. If you ever see it referred that way, that's what they're talking about. This is converted by a enzyme called 5-alpha reductase. Okay, this is an important enzyme because this is you'll find that dihydrotestosterone has much more adrenergic activity than you would see with just testosterone by itself. So even though you'll see a lot of the products that we give are testosterone based, a lot of them get converted over to DHT by this 5-alpha reductase. We also, if you guys remember back to our urology section, we've already talked about some of these 5-alpha reductase inhibitors. We'll cover these briefly here as well. Normally, testosterone can also be converted to estradiol by aromatase. This is a really important enzyme, especially when you're talking about things like breast cancer and whatnot. We'll mention that again when we get to the OB-GYN section. A lot of these steroids, especially things like testosterone, get metabolized in the liver, which can lead to some side effects, as we'll see in just a little bit. And basically the mechanism here is that once testosterone binds to intracellular androgen receptors, usually in the nucleus of cells, they'll be able to affect gene transcription. And so this is where you get all the other physiologic effects that occur secondary to these effects on gene transcription. So other things that are important to note here for this process for how androgens end up getting released. It's not just a one-step process from the testes by themselves. Normally, this is going to be regulated through kind of a complicated process through the hypothalamus, the pituitary gland, and then ultimately the sex organ. So you'll see very similar diagram when we talk about the OB-GYN section, where we're talking about the hypothalamus, the pituitary, and then the ovaries, right? So how this process works is that normally hypothalamus is going to release GnRH, which is gonadotropin releasing hormone, which will then have a positive effect to stimulate the pituitary gland to release luteinizing hormone and follicle stimulating hormone. These are the same hormones that women release in order to help stimulate the ovulatory cycle. Okay. Both of these have positive effects on the testes to help produce testosterone. This is also where you get sperm production, and also another product called inhibin. Okay, this is important because these are all negative feedback loops, right? Once the testes produce enough testosterone and the brain senses, hey, we have enough testosterone around, this has a negative feedback inhibition, meaning this will end up shutting down this process, right? So if you have a relative lack of testosterone, if you're not producing enough, it's going to stimulate your hypothalamus to release more GnRH and more LH and FSH. If you have too much testosterone around, this is going to shut this process down. This is the exact same reason why if you have something like a bodybuilder who is injecting exogenous testosterones and other androgens, they end up getting testicular atrophy because of the fact that once they have enough testosterone floating around, it shuts down this process. You're releasing less LH and FSH, and thus the testes don't have anything to produce, so they start to atrophy. So that's a common side effect from injecting exogenous testosterone-based products. So what are some different products we have available? So we have naturally occurring products. We have things like testosterone and dihydrotestosterone that the body normally makes. You find that a lot of the products that we have are going to be testosterone based. You have things like androgel, depo-andro, depo-testosterone. The big thing here is that most of these are either going to be injectable products or they're going to be transdermal products. So like androgel is a gel-based product you can apply directly to the scrotum. You'll have patches that you can apply as well. It's important that we're not going by the oral route. We'll talk about why that is in just a minute. And then most of those androgens, when they come into contact with 5-alpha reductase, they get converted over to DHT. Okay, DHT again being the more active, potent form of testosterone. Okay, it's kind of the moneymaker. That's really what's doing a lot of the activity to produce the adrenergic effects. There are also some other agents you may see used occasionally. I've actually not ever seen these used before. Most of these come as a PO formulation. You have things like methyltestosterone, fluoxymesterone, oxandrolone. These all will have positive adrenergic effects, but you'll find that orally administered testosterones and androgens are going to have hard effects on the liver. Okay, we'll talk about those in just a minute. But there's some other ones you may see being used out there. But again, for the most part, most people end up getting put on testosterone-based products. So what happens when androgens react with different types of tissues? Normally, androgen receptor-mediated effects of testosterone include development of the internal genitalia. This will also cause stimulated skeletal muscle effects, erythropoiesis, and then you'll also have things like hair follicles and things like that being developed. So this is normally what happens just during puberty for young men and ladies. They have development of these different tissues, right? These are why these are anabolic steroids, because they are producing growth, right? They're stimulating growth. When you have, and again, hate to say it, guys, but all of you produce a small amount of estrogen because some of that testosterone gets converted over into that by aromatase, and so this can be important for affecting things like libido and also closing off those epiphyseal plates on the bone itself, so that will have some effects on bone maturation as a person grows. Therapeutically, where do we see our androgens? And we actually have some anti-androgens that we'll see used occasionally as well. Big things with the androgens is you'll see them being used for male infertility. The T here stands for testosterone, and then the MT stands for methyl testosterone, is that other product we talked about. This is where occasionally you'll see them being used. Again, for the most part, testosterone gets used kind of over some of the other ones, the oral products, as we'll see why in a minute. So male infertility, especially if the man is not producing enough testosterone on his own. You may see this if a patient has loss of gonadal function. So if they have testicular cancer and they had those removed, you need to replace that somehow. Okay. We'll see that the testosterone and androgens have positive effects on the bones. So it can actually help to prevent osteoporosis. And occasionally, you may see it in hormone replacement therapy combined with some androgens. We'll talk about that more in the OB-GYN section. Occasionally, for inoperable breast cancers, you may see this fluoxymestrone being used to help kind of limit some of the estrogen effects on those tumors. And then also, we will see these being used for the anabolic effects in patients who have wasting conditions. So for instance, if you had trauma, if you have AIDS, bad COPD, conditions where the patient is not able to maintain good nutrition and is starting to have muscle wasting and things like that, you can use some of these androgens to help kind of build up back that muscle mass. So something like oxandrolone, testosterone could potentially be used. All those will have positive effects on building those tissues back up. And then for the most part, anti-androgens are going to get their mainstay of use in metastatic prostate cancer because we know from our urology talks that the prostate is stimulated by androgens. So if we can block that effect, that will help to reduce the development of those tissues. And then sometimes for hirsutism or abnormal hair growth in women, this can be, you can use an anti-androgen to block this effect. So again, mentioning the formulations here, testosterone, they get metabolized pretty readily in the liver. And so for the most part, it's not useful for oral administration. So that's why we use things like methyl testosterone or other formulations in order to help bypass that liver metabolism in order to have it be more active. The other thing you could do is just to give it an injection or transdermal formulation. So sometimes you'll see them being put in these kind of oil-based products that will have kind of long-acting effects. So that's why you have like depot testosterone, because it forms a nice depot effect in the muscle and it has slow release. Other than that, you'll see transdermal formulations being used, either patches or gels and things like that. Mention some of the anti-androgens. You'll find that anti-androgen or androgen receptor antagonists, things like flutamide and bicalutamide, are available out there. So those are some of the ones you may see being used for more advanced prostate cancer. Basically, those will just block the androgen receptors and prevent those natural androgens from interacting with those receptors. We already mentioned spironolactone, which has some mixed androgenergic receptor effects, which is why you can see things like gynecomastia in guys who are taking spironolactone is due to those androgen receptor antagonist effects, right? The other big things we'll mention here are the 5-alpha reductase inhibitors that work to block conversion of testosterone to DHT. You guys remember like finasteride, those are big ones there. Those are used mainly for prevention of or try to limit some of the growth of the prostate tissue as well, if you guys remember back to those lectures. So side effects. What happens when you have too much androgen receptor activity? These are, we're going to see prostatic enlargement for the guys. So again, activation of those receptors leads to further tissue development, which can worsen BPH or worsen prostate cancer if the patient suffers from that. You can see testicular atrophy and azoospermia, as we mentioned, due to that negative feedback loop where if you have exogenous androgens being given, that's going to decrease the amount of LH and FSH the pituitary was releasing there. Due to conversion of some of those androgens over into estrogen, you can see that gynecomastia there. And then we also know the bacne or the horrible acne you can get for excess androgen activity. I can see that a lot in a lot of bodybuilders and things like that. They're using exogenous androgens. You'll find they have pretty bad acne for the most part. You can see in some erythrocytosis that can be problematic if their hemoglobin gets too high and cause some sludging, but it's not seen in most patients. And then also due to some of the mineralocorticoid effects, you may have patients have more sodium and water retention. So that can be problematic in patients who already have CHF or other cases where they can't manage their fluids very well. Okay. So biggest things we worry about with the oral products, those are those 17 alkylated androgens or the methyltestosterones. They can have negative effects on the liver since they go through there and get metabolized pretty readily. So you can see cholestasis, see reduced HDLs, and possibly even hepatitis. All right, so this is really the biggest problem you see with oral administration of these drugs. This is why we try to avoid it if we can. Okay. And then finally, if women are taking androgen-based products, you do see some masculinization. You can see some abnormal hair growth. You can have a deepening of the voice. Sometimes they'll even get like kind of like a round, kind of their chin will actually kind of develop a little bit more of a kind of a masculine jawline. The problem with some of that is it's not really reversible in a lot of cases. So, if a woman was taking excess androgens and their voice dropped, that may or may not be reversible. So that can be problematic for some of them. So some of the things that we'll use to treat BPH, we already kind of talked about these previously, but you can use things like finasteride or dutasteride. Again, remember that these are very teratogenic, so do not let pregnant women or women of risk for being pregnant handle these drugs, because you always want to make sure you have good conversion. You really don't want to mess around with hormones in a developing fetus, so these drugs would be contraindicated for sure for those patients. And then you can also have GnRH analogs. So these are basically things that look like GnRH to go back and activate those receptors on the hypothalamus. Essentially, you're trying to activate that negative feedback loop there to decrease, ultimately, release of LH, FSH, and also production of testosterone. So two big ones include goserelin and leuprolide. Those are usually injectable products. I'd see them probably most frequently used in kids who have a history of, say, some sort of hypothalamic tumor that's been removed, or a pituitary tumor that's been removed. They will sometimes use these drugs in order to help kind of stimulate that process. But you could also use it potentially for patients who have a testosterone-based tumor, like prostate cancer, to help kind of lower a production of testosterone in the body. So a couple of different uses you may see it being used here or there. So again, just to kind of give you an idea how that process would work, if you have kind of overstimulation of GnRH here at the hypothalamus, these agonists will end up having that effect on the negative feedback loop and ultimately decrease what's coming out of the pituitary gland, less LH and FSH, and then ultimately would have less testosterone being produced. You can also see here where the finasteride and dutasteride are working as 5-alpha reductase inhibitors, so you have less conversion of testosterone to dihydrotestosterone. And then finally, androgen receptor antagonists, things like flutamide, spironolactone will also be inhibiting these receptors as well. So different places to block the effects of androgen throughout the body. Okay, next up we'll talk about adrenal cortical insufficiency. So what do you do when your patients are not having enough adrenal activity? You will see that corticosteroids, we've talked a lot about these before, they're going to be affecting gene transcription by binding to those receptors within the nucleus, right? We mentioned our glucocorticoid receptors previously. We know how they work on inflammation and can suppress the immune system and things like that. There's also the mineralocorticoid receptors, where things like aldosterone primarily work, and these are really, really important for maintaining good water balance and blood pressure within the body. Okay, these also lead to reabsorption of things like sodium from the distal convoluted tubule to also help retain water and salt. Okay, if you have a disimbalance here and you have too little mineralocorticoid receptor activity, you're going to see a lot of hypotension. You'll see a lot of leaky fluid, or a lot of leaky vessels leading to third spacing of fluids. Very problematic for some patients. So how you can replace that is by using things like cortisol or hydrocortisone. This is what your body is naturally releasing anyway. Normally, you're producing about 10 to 20 milligrams per day, and it follows kind of a circadian rhythm, which means that throughout different parts of the day, you may have kind of peaks or troughs in how much hydrocortisone is being kind of released from the glands, right? Increased stress will also increase the release of that, which is why you can see the cortisol levels spike up in relation to things like severe infection, like sepsis and things like that. So Chronic adrenal insufficiency is termed Addison's disease. Again, as I mentioned here, hypotension can be a big thing due to those mineralocorticoid effects. Also see a lot of weakness, fatigue, and weight loss. Also, you have problems maintaining good glucose, right? Because normally as a stress response, your fight or flight response increases glucose levels within the bloodstream. But if you have problems with your adrenal glands not working properly, this can be problematic. Okay. Even minor events, even things like acute stresses, colds, things like that, all can cause acute adrenal insufficiency, which can lead to that circulatory shock just due to them being unable to maintain their blood pressure and lead to death. So most of the time you're going to see those patients being put on oral hydrocortisone daily. Hydrocortisone has a preferable activity at the mineralocorticoid receptors than it does at the glucocorticoid receptors, right? This is why we don't use something like prednisone or dexamethasone because that has much more glucocorticoid activity. Hydrocortisone has a lot more mineralocorticoid activity. So, and sometimes you'll even see them get stress-based doses. So if they realize that they're stressed out or they get sick or something like that, we'll give them increased amounts of hydrocortisone to help supplement that. We may also use certain steroids which only have mineralocorticoid effects. So I see fludrocortisone or Florinef is a brand name for that, being used most frequently for patients who have very severe adrenal insufficiency. That really helps them maintain their blood pressure much better. And then again, other things that are long-acting steroids, non-salt retaining steroids should be avoided for the most part. So those are those other glucocorticoids like dexamethasone or prednisone that I already mentioned. The last thing we'll talk about today is going to be thyroid pharmacology. So what are some different things we can do to affect the thyroid gland? So several things that can occur with the thyroid gland. You can have hyposecretion, several different levels where this can be affected. And you'll find this is similar to the androgens we just talked about, where both the thalamus and the pituitary gland can all be affected. You'll see that that can lead to primary, secondary, or tertiary lacks of thyroid gland. You'll find that most times these are going to be treated by hormone replacement. So we'll have drugs that specifically replace the thyroid hormone that your body would naturally produce. And then you can have hypersecretion as well, where you can also have primary, secondary, and tertiary causes for this, which again, I'm not going to delve super in depth into unless it's necessary for kind of discussing the disease state. But we'll also have certain drugs that actually help to inhibit the effects of producing too much thyroid hormone. Okay. So you can see this chart, it looks very similar to what we saw with the androgens. And essentially what you can have happening here is the hypothalamus will end up releasing thyrotropin releasing hormones, this TRH here, which will stimulate the anterior pituitary gland to release thyroid stimulating hormone, or TSH, right? If you guys remember, this is what we're mainly going to be measuring to check our activity of TSH when we have hypothyroidism. Anyway, TSH will go ahead and have positive effects on the thyroid gland here in order to help increase release of T4 and T3, which are going to be our primary thyroid glands that we'll talk about more in depth here. Essentially, this all has negative feedback loops as well. So if you have high enough levels of T4 and T3, you'll end up having negative activity here at the hypothalamus and the pituitary in order to help decrease release of those their individual hormones, right? So very similar process here. Notice here the iodine is going to have an effect here as well, where if you have an appropriate amount of iodine in the diet, you'll have stimulation of the thyroid gland. If you have too much iodine, this actually has an inhibitory effect here as well. So we'll talk about why that is in just a minute. So what are some of the agents that we have to replace thyroid hormone? Well, essentially, levothyroxine is probably going to be the number one agent they're going to be using for these patients. And then basically, this is just synthetic T4, right? So this is normally called Synthroid, is the brand name we're going to see used most often. Basically, it has pretty consistent potency, has good prolonged duration of action, so around 6 to 7 days or so. So very nice acting medication. It also has a couple different dosage forms available. Usually this will be given orally. Sometimes you can actually see this being given parenterally through an IV. The place where I saw this most often was for patients who are undergoing organ harvesting. So organ donors, they will oftentimes have major issues in endocrine function after they are pronounced brain dead. And so we can use thyroid or levothyroxine in order to help regulate this. But keep in mind, thyroid hormone, T4, is going to be bound up by lots of different drugs, so iron, calcium, aluminum, all can be affecting absorption, so you need to separate those drugs out to make sure they don't have any issues with absorption with that. Okay. Also, if you have intestinal flora alterations, things like, if you're taking antibiotics and that's kind of messing up with the GI flora, that can also affect absorption as well, lead to inhibited absorption. You'll find that increased induction of hepatic enzymes like the P450 system may enhance excretion of the drug or metabolism, so that can be problematic. And sometimes you'll actually use this as a suppressive therapy in some cases. It's pretty rare. Most of the time you'll see it's used as replacement, but sometimes if you really need to kind of cut down on TSH levels of the TRH release, you can use higher levels of levothyroxine to kind of suppress that. The other product, we have a few other ones. So we have something that would just be T3. We'll talk about some of the differences here in just a little bit, but T3 is the active form of thyroid hormone. T4 itself has to be converted over to T3 through normal metabolic processes. So levothyroxine takes a little while to work because it has to be converted over to T3, but this liothyronine or T3 can be active immediately. So this one does not get used nearly as often, but if you need a quick onset of action, this is the drug to go to. This one may require a little bit more frequent dosing than you may see with levothyroxine. Also has higher costs associated with it, so this is why we don't use this one super often. And then you have one drug, Liotrix, which is actually just a combination of T4 and T3. Thyrolar is the brand name for that one. This one is oral only, but it has a more natural ratio of T4 to T3 that your body normally produces. So this is kind of what you would naturally see if you were to measure blood levels of T4 and T3. So this was meant to kind of be a little bit more natural. I've never seen this drug being used, but you may see it out there occasionally. Obviously, the major cases of where we would use thyroid replacement hormone is going to be for cases of hypothyroidism, as you might imagine. For patients who maybe have a Hashimoto's thyroiditis, where they have kind of the autoimmune destruction of the thyroid gland, mixed edema or severe thyroid deficiency, if they've had a subtotal thyroidectomy, would be another good case to do this, or if they've used radioiodine to ablate the thyroid itself. So these are all be good cases to replace that activity. How this works is that the thyroid hormone will enter the target cell, wherever cell it happens to be, and T4 ends up getting converted over to the active T3. This will then enter the nucleus, and then you'll find that there's a few different intracellular receptors they'll bind to, but then after this point, it will start to regulate gene transcription, right? So it'll be able to affect things like formation of new RNA and other protein byproducts that are needed to have normal thyroid function within the body. So we also have a few agents that act as anti-thyroid drugs. So these would actually help to inhibit the activity of these thyroid activity if you had too much T4 and T3 floating around. So two individual agents here. You have propylthiouracil, or PTU, and you also have methimazole or tapazole. Typically, methimazole is a little bit more potent than you see with PTU, but you will have some issues if you have liver dysfunction with that one, so maybe where PTU gets used more frequently. For the most part, they get well tolerated, but you may see some agranulocytosis associated with this very rarely. How how PTU and methimazole works is it actually interferes with the oxidation step of iodine from being included with this peroxidase enzyme, and so it basically prevents this organification, or the step where iodine is added on to the thyroid hormone precursor. And so basically by depleting those thyroglobin stores, you prevent actual thyroid hormone from ever being produced in the first place. So for instance, if you had Graves' disease, which is an autoimmune disorder as well, but basically you have these thyroid stimulating hormone receptor stimulators, the antibodies go in and activate the same TSH receptors that your pituitary gland would normally try to be activating. Or if you had something like a multinodular goiter, if you were trying to shrink the gland before surgery, this could also be used in those cases. So just to give you an idea how this process is working, essentially when you have thyroid hormone, basically iodine's coming into the thyroid gland here, you're preventing the step, this peroxidase, where you have iodine being converted into iodide that gets added onto this step where it gets added on with thyroglobulin and tyrosine. So you can't produce this T4 and T3, and that's why you don't really get any extra thyroid hormone being made when you have things like PTU or methimazole on board. Some other agents you can use potentially include radioactive iodine. So this is sometimes used in order to basically iodine gets preferentially uptaken into the thyroid gland when you ingest it, and so you can actually use a radioactive iodine to go and either use it as a thyroid scan, or it can actually be used to cause actual ablation of the gland itself. So you can kind of have increased uptake, and will actually work to that radioactive effect will kind of destroy the tissue essentially, and so you can end up seeing good effects if you have like thyroid cancer and things like that. It can be useful. Obviously, high incidence of delayed hypothyroidism because you're basically destroying the tissue itself. You can also use iodides either as a form of stimulating thyroid gland production or using it to inhibit it, right? So iodides can be used to treat hyperthyroidism, rarely to use it as a sole therapy itself. Basically, giving too much iodine actually ends up inhibiting that process as kind of a negative feedback loop. Usually you'll use it in addition to patients who are on PTU or methimazole as well. And so if they have thyrotoxic symptoms like hypertension, sweating, all the kind of things you see with thyrotoxicosis, you will see some benefits there within say 2 to 7 days or so. Usually with iodine, the biggest thing you're going to see is rash. You can also see some swollen salivary glands, probably the most common things you're going to run into. In some cases, you can actually use iodine as a prophylactic if you're worried about radiation exposure. So just in case the bombs ever drop, actually using iodine to keep your thyroid gland kind of stocked up, because usually in nuclear fallout, the most common isotope you're going to run into is radioactive iodine. So you can actually end up trying to block uptake of that radioactive formulation by having your thyroid gland kind of already stocked up on regular iodine. Kind of a interesting aside in case you're ever into biological or chemical warfare. So just a little brief review of kind of how these iodides are working within the thyroid gland. You can kind of see several steps that occur to iodide when it comes into the gland itself. So once it gets trapped in here, you basically have this conversion from iodide over to iodine as a peroxidase enzyme that is working here. And again, when you have high levels of iodide around, this actually inhibits this process. So it's why having too much iodide around actually ends up causing decreases in the amount of thyroid hormone being released, whereas if you have normal amounts, you can actually have some stimulation of it. But essentially, the big step we are concerned with here is this organification. This is producing basically the iodide gets added onto these tyrosine molecules, and so you end up having this MIT, which is the monoiodotyrosine, and diiodotyrosine, or DIT. And this will be important because these end up getting added together to form your T4 and T3, right? And this step can also be blocked by high levels of iodide as well. As I mentioned, two of those molecules will form together, so it'll actually form thyroxine. So basically, if you have one molecule of MIT plus DIT formed together, you'll end up having T3, which is the active form. You can have one inactive form called reverse T3, which I'll mention in just a second. That's not really useful. But if two molecules of DIT come together, that's where you get T4. And that's synthroid, basically, or levothyroxine is what you have there. Again, typically you're releasing about 5 times more T4 than you are T3. So that's why that liothyronine was looking very similar to the actual ratio of T4 to T3 is in the body. So here again, you just see this picture how that step is occurring, where you have the iodine coming in, gets converted over to iodine, and gets added onto that tyrosine molecule to make MIT and DIT. Once the hormone is there, it's going to be able to cross the apical membrane and undergoes that proteolysis, where it basically removes the thyroglobulins, and so you can end up having basically release of the hormone into the system, right? T4 itself is not going to be active, even though it's circulating in the bloodstream, but it does get converted over to T3 by having this deiodination. This is also another thing that can be inhibited by high levels of iodide within the body. Looking at that deiodination step, you can see that it occurs at a couple of different places. You can have it occur in the wrong place and produces reverse T3, which is actually inactive. So I'll show you a picture of that in just a second here. So here you can see that process where up here on the top we have our T4. Again, this is the inactive formulation. This would be our synthroid or levothyroxine. If you remove the correct iodine here, you get T3, that liothyronine, which is the active form. Otherwise, you get this reverse T3, which is going to be inactive. So again, most frequently, this is what we're giving for hormone replacement therapy, where this is being the active form that actually is the business end of the molecule, so to speak. So other products you might see, sometimes you'll actually see iodinated contrast media being given sometimes for emergency treatment of thyroid storm. This is where the body just has way too much thyroid activity, very potentially bad from a cardiovascular standpoint, and sometimes this will actually be used to help inhibit that conversion of T4 to T3. It's nice because it's a relatively non-toxic kind of product, but it can actually be used in some adjunctive therapy or some other things to help kind of deal with those problems of thyroid storm. So anyway, that's it with the endocrine section. If you have any questions, please let me know. I'll try to answer anything. Otherwise, we'll have a review on Wednesday, and we'll go from there. All right, thanks so much.